He took a hit.
He took a hit.
All right, so I'm going to take the opposite approach, not necessarily all the same arguments. So this is our current venous stent landscape. We all know we have the wall stent now approved. And then we've seen all these stents go through IDE trial, relatively similar timing. But we've even seen some of them go away now. So Vici's gone, Venova went away and it came back. And now Duo went away and hopefully it comes back. But we still have, these dedicated stents available. And what we've seen clinically, for the most part, with little exceptions here and there, these stents can be used pretty successfully. And in this argument, I'm going to say that the result wasn't dependent on the stent, right? It was dependent on other things. So what's the problem we see? Well, we see stent failure. That's what we need a new stent if these stents aren't working, right? What is stent failure? It's stent occlusions. It's also, there's some complications, including contralateral jailing that Brooke talked about, where the stent fails, right? So is it the stent? So stent patency is a problem, right? This is a meta-analysis that was just put out. And by the 36-month, primary endpoint or primary patency, 59%. We've seen anything from 50 to 80, depending. This particular group had just over half was post-thrombotic. So if you looked only at post-thrombotic, it'd even probably be worse than that. Whereas the non-thrombotics are pretty high. So these are bad problems. We've all shown these pictures over and over again to illustrate that. They're tough to deal with. There's also these additional stent complications. I always put failure to improve because I think I see one of those every week in my clinic. Like, hey, somebody put a stent in me and I didn't get better. What is this? Stent migrations and stent pain from oversizing we see. So let's look at them each. Looking at stent occlusions first, is this the stent's fault? Well, when you look at these procedures to get success, right, you need good inflow. You need quality of inflow vessels, your femoral, your profunda. You need the right landing zone picked. You need the right access to make that happen. The conduit, yes, you need to dilate it correctly, post-dilate correctly, pick the right sizes. Yes, your stent has to be durable, and then outflow parameters, right? But there's only one on this whole list of things you need to have a successful outcome. That's the actual stent. And there's a lot of other things that play in. When we look at why the failures occur, we look at Aubrey, 200 patients right across all disease subsets, and we looked at the 12 patients that occluded. What we see is it's the post-thrombotic and one of the ZVT cases. We see all had involvement, most of them, other than that one nibble, all had involvement of the common femoral vein, all had significant, or most had significant two-vessel inflow disease below the affected common femoral vein. And we looked in more detail at each patient. We see that there was a good number of patients who had missed disease in the common femoral, so stents landed above the ligament or at the ligament, and then disease below it untreated. A good number of patients, including some that also had untreated common femoral disease, that had inadequate inflow vessels. Then we had one patient with a missed atresia. We had several patients with technical errors that were most often in combination with the other issues we saw. And then we had issues with anticoagulation decisions that may or may not have been appropriate, either made by the physician not recognizing the complication that had occurred or by the patient who was just non-compliant. None of these really involved the stent. So let's look at some of them. So this case 2 here was in the trial, and you can see they had an occluded common femoral vein. The yellow mark is the top of the femoral head. It's on subtraction, so harder to see. Lesser trochanter is a little shaded out in the picture to the left. But you can see it was totally occluded. So it was treated with balloon venoplasty alone, which we know is not effective in vein disease, right? But they put the stent only at the ligament up there and didn't treat it below. And you can see right below the stent edge, even that one spot, there's this chronic disease hanging out in there. That one lasted a while, but those stents are high risk with stuff below them like that. The second one over there, you can see in the bottom right ultrasound picture, that was immediately after stenting, and you can see all that chronic stuff with a super narrow lumen below the edge of the stent. And the same thing, they treated that area only with venoplasty. So there's missed disease. Here, they stented into the femoral vein, which on their pre-op ultrasound was segmentally occluded and went straight past the profunda, which you can see in that ultrasound on the right. You can see that it's going straight across the profunda orifice. And that one eventually occluded when it was unrecognized and anticoagulation was stopped. Here's another one. This was not in the trial, but just a different patient, taken down into the femoral vein, past the profunda, opened several times, but then eventually the stent was lost. This particular patient I showed in a talk earlier, again, access to the common femoral, leaving distal disease, despite adequate landing zone, this stent occluded. not a stent problem. This one's another one from the trial. This patient was stented to above a occluded profunda and femoral vein with only a tiny flow channel. And these are all done by experts, by the way, because it's people enrolling in trials. so I'm wondering what's really happening out there, right? We do know that inflow is what's really affecting these stents, and that the patency goes down. This is the July classification. We also Black repeated what we had done with the Aubrey trial in his patients and saw similar things. So technical issues, hematologic issues, flow issues, areas without stents, device failure in 4 patients, but he was the top enroller and had the most Vicis implanted in Europe. And those were, I believe, Vici fractures. So, okay, we don't think that the stents are causing the occlusions. It doesn't look like it. So then if it's not the stent itself, we don't need new stents to fix occlusions. We need education, technique, inflow issues, right? So what about stent complications other than occlusion? Did those require a new stent? Well, stent migrations, right? We see here, this is, see in the middle picture, one of 2 stents. One's in the heart, and if you keep watching this video here, you'll see the other one, same patient, in the pulmonary artery. And then did the guy say, oh, shoot, we need a new stent, look what this stent did? No, he actually liked stents. He put in some more right after that. So there's one in the external iliac vein. He then has a skip area, which you just really don't do. And then he puts in this one, which kind of jails the external, and then he goes and jails the contralateral iliac. So he didn't think there was a stent problem. I don't think so either. So here, another migration case. This patient, they said he had an 80% Maytherner on IVUS. The gentleman putting it in was pretty new to venous stenting. There's the stent there in the cava you saw in that study up there. There's his Maytherner, there. Okay, he didn't really have one, and his vein measured 18 to 19 throughout the whole common iliac and almost 18 in the external. They picked an 18 by 60, but they didn't have it. So then he got a 16 by 60 and the stent flew. So is this a stent problem? Probably not, right? It's more inappropriate sizing and selection and patient selection. You probably didn't need a stent at all. So is this our response to migration, which is what our response should be when it happens? Nope, this is our response, right? So what happened? We said we need better stents to prevent migration, and the Vici went off the market, and they said, stent migration's the problem, it's the stent, and it's not come back. But it really wasn't the Vici. Vici may have had other issues, but that wasn't it. So then we look at failure to improve. Well, I'm not so sure that's related to the stent, right? That's related to people not needing them, maybe to technique, measuring. Stent pain, oversizing. Probably not related to the stent itself. These stents are usually 20s put in. I've even seen 22s put all the way into the common femoral vein with the wall stent. So then it's probably related to something else, right? Inappropriate stenting and sizing. Contralateral DVT is the one place, maybe, I'll give you, and Brooke had this in her argument, because it can be a little challenging to put them right at the confluence. When I first started doing the newer stents, I almost went back to Z stenting. I was getting so frustrated with how many I was jailing, and I taught people not to do this. But I've got it pretty much down now where it's a rare case where I jail, but it does take a little bit of nuance to it. So I don't think it's perfected. It's still hard to do it right. So maybe some technology adjustment there, but mostly it's technique. So what do we need if I don't agree we need a new stent? I say we need education. Venous outcomes are detail-oriented. You can't just throw these things in. The principles and techniques are different than arterial and arteries. You're limiting your stenting, for example. Here, you want to maximize the stenting so you leave no disease. There's certain things that we do different in veins that you can't do the same. Venous disease is just not emphasized during training. I mean, my fellows, I'm not sure I know what they look like. They're at another hospital. They really still need more education. And then there's still PR issues, right? We need more PR. Dogma states arterial cases are so much more important. It's just a vein. I'm so tired of it's just a vein. You lose a leg, you lose a life. Arteries are important. I agree. I trained in them. I agree, fix them. But this ruins your life. Ruin your leg, ruin your life. So these are just some of my patients. That one on the left-hand side, the gentleman, the tall one, he was about 30-something, maybe a little older, and he has near disability because he was treated for bilateral lymphedema. His legs were huge, and the guy had missed cable disease for years. Callie in the middle left there had a missed diagnosis of an acute iliac occlusion. Treated for the PE, sent home, then had trouble resuming dancing. The guy to the right was shot on duty, had his iliac vein tied off, 20 years of pain, and said he was going to kill himself if we couldn't figure out how to fix it. The guy on the right was actively dying of liver failure from occluding his atrial caval junction. These patients will argue how important this is. And this woman, if that didn't convince you, is very sobering. Came to me with recurrent stent occlusions, now very poor inflow, kept going down. We tried our best to keep it open, and this is her obituary. And her family felt that she certainly had other issues, but her family felt that her vascular disease contributed to her ending her life, and they wrote it in the first sentence of her obituary. So these cases are important. Also, what we need, technology for inflow management, right? This is our biggest challenge. We all struggle here if we treat these post-thrombotic patients. So I do think these cases can be done with current stent technology. Mechanical issues do occur, but it's very rare. Stent failure complications are usually related to untreated disease, judgment errors, noncompliance, poor inflow. So in my mind, we could spend our money on increased PR, education, and technology for inflow disease. I don't know what to say about that allergy. I got one right now. I don't know. All right.
Thank you, Erin. Thank you.